has provided many presentations for us on a variety of topics. She completed her medical school, internship, and residency at Denise Furlong. Her fellowship at Illinois Urogynecology. And Dr. Furlong strives to fill a void in the healthcare world for the purpose of providing a safe, compassionate, patient-focused environment to empower women to live happier, healthier lives. She is double board certified in female pelvic medicine and reconstructive surgery, obstetrics and gynecology. And she also has integrated medicine, which she received her degree one of the list. So, anybody know what integrated medicine is? I will let you explain it. I do know, but I don't want to take over your explanation. And she does speak Spanish also. And her office is in a block, 4938 West Main. So,
Thank you.
you're welcome.
Welcome, everybody. I'm Dr. Furlong. I've been practicing since 2004 when I graduated residency. This is kind of in my way. So can I bring this down? Is that okay? Just so, oops, did I press something here? I think I pressed the volume button.
That's okay.
Thanks. Just kind of seems, thank you.
In the way.
Is that a speaker for me?
Yep.
Oh, okay.
You have to speak.
Got it. Thanks.
Okay.
Oh, that's better.
Okay, good.
Looks like it has a little brain up in there. Okay. So I graduated in 2004. I've always had an interest in women's health. I went into general OB-GYN for 4 years. And then after that, I did a fellowship in urogynecology, pelvic floor reconstruction. Over the last 10 years, I've owned my own practice. And 2 years ago, I decided to add a fellowship in integrative medicine because I really felt, you know, as I was taking care of women, there were a lot of questions that they had for just their general health and well-being and things that were not mainstream medicine, where, you know, I have a blood pressure that's this number and I give you a medication to get it down. I have a diabetes that's this number and I give you a medicine to bring it down. My patients were looking for more integrative type of treatments. Not that I treat diabetes or high blood pressure, but they were looking for things, you know, they were taking all sorts of supplements. They didn't know where they were. They were getting from Amazon or Costco or their grocery store. They were getting them online. And, you know, some of these did concern me because I wasn't sure, you know, what they were taking, if it was correct. And so over time, I just thought that doing an integrative medicine fellowship would allow me to really give additional care to my patients. And it's not medication that I'm giving, it's more lifestyle and supplements and just how to live really healthier. And a lot of things, you know, what I have found is when you treat a woman, you really treat the whole family because we run everything. We buy the groceries, we cook, predominantly it's the woman. We're responsible for many of the household functions. And so when we change how a woman is, you know, living her life and we make it healthier, that one person changing what she does or thinks in a healthier way and teaching her empowers her children, her partner, her girlfriends, her community. So it's interesting because I may be only teaching one person at that interval and that moment, but I know that word gets spread. So I always feel like women's healthcare is so much more than just women. I mean, I should really be called family or community healthcare, family and community healthcare, without having to take care of men, which is kind of, which is why I went into a female predominantly field, because it's just nice to have female to female and be able to talk about all of our topics and be in a room in an atmosphere that's comfortable. Today, I'm talking about sex, though. And so it does include men and women, or it could include other sexes, right? As we're learning, as our ability to have less fear of speaking out about our sexuality and what pleases us and what we want, we're learning about transgender, right? Gay rights. And so it's nice that I think people don't have to feel as much as they have to hide everything that they feel or feel ashamed. And those taboos and those walls are starting to come down, as they should. Okay, so welcome everybody. Let's talk about sex, which I thought was cute. Synonyms for sex: sexual intercourse, coitus, copulation, fornication, lovemaking. And so I usually ask the audience here, any other words? And you don't have to speak up. But I have been in other forums that people have said a variety of things like whoopee, let's see. Does anybody have any they want to share? Any thoughts? Nookie nookie, right, right. Let's get it on, right? Good stuff. All right. There you go. And sometimes it's just the look, right? Like, right? So, everybody has different ways on how they communicate whether or not they want to start becoming intimate. And it's interesting because for me, I've read a lot about sex, and I still have yet to find what is the actual reason that people have desire for sex or want to have sex, right? And it's interesting because if you think of as children never think about it, right? They just don't. They're asexual unless they unfortunately have situations that change that for them as children. But in general, children are asexual until they start going through puberty. So our hormones have to do with it. But which hormones? What hormones? And how does it change us? Like, does it change up in our brain? Does it change in our sex glands? Like, is it a combination of everything? Like, there's not one specific thing that science can say that's what starts it. And that's the cascade. And if we add that to everybody's drinking water, they'll always want to have sex, right? Because number one question my patients ask me is, how do I get it back? I've lost it. I have no interest in sex. And I'm like, well, if we could figure out way back when, we started going through puberty, what it was that ignited it and gave us that, we could just add that back, but we don't know. So it's very complicated because we know that when women or men, but I don't take care of men, so I can't speak about them, but when women lose their sex drive or they lose their ability to orgasm, our ability as medical professionals to give that back has its drawbacks, has its limitations, right? So that tells me that there's not really one specific thing that causes us to have a sex drive, to have a libido, to have an orgasm. Okay, so those are some synonyms for sex. And then what is sex? So I always like to go back to my Webster's dictionary definition because I love Webster's. And my kids are always using it because they're in grammar school. So I flip through and I'm like, oh, here it is. Sexual contact between individuals involving penetration, especially the insertion of a man's erect penis into a woman's vagina, typically accumulating an orgasm and the ejaculation of semen. So that's what Webster says, right? But everybody's got their definition of sex, whether it's between a man and a woman or a woman and a woman or whatever that means for the person who's having sex. As well as masturbation, right? So you don't have to have sex with another individual. Some people never have sex with someone else and may masturbate or may never masturbate. There's oral sex, there's anal sex, and then, of course, like I alluded to, sex between people other than heterosexual. This talk is predominantly about heterosexuals, though. Okay, so if I don't allude to other types of relationships, it's just because that's the way this lecture is written. Okay, so let's talk about anatomy. And, I am always the most popular person at a party. So it was really funny because, I am divorced, but when I was married, I went to a party with my then husband, and we all had to put one word on our back that described us. And I was like, I'm going to put vagina. Oh my gosh, my ex-husband was mortified, just mortified that I would put that. I'm like, I guarantee you that I'm going to be the most popular person. This is like a 200-person party. So I ended up putting something else on my back. I forgot what it was, but word got out that I wanted to put vagina, and everyone was very curious. And sure enough, I had a forum of giving a talk about G-spot and all sorts of other things. So it was very interesting. But, it always makes me interested to hear, like, I had a lot of couples and the guys were like, at parties, they wait until their wives like go, like, I go to the kitchen and I get cornered by 5 men. How do I please my wife? Why is my wife, this? What? And I'm thinking, it's just funny. It's interesting. So, I always go back to basic anatomy and the things that we know and the things that we don't know. Basic anatomy on a woman, clitoris. So for a woman, if I don't know if you guys have ever seen think it's on, I forgot what network, but it's Orange is the New Black. And the girl's in prison, and she goes, one of the girls goes into the bathroom, and she's like, "Oh my God, my pee hole is not my vagina hole." It's this whole thing, and I have to laugh because I have so many patients that tell me that. And it's basic anatomy. Where you urinate that opening is separate from the vagina. Okay, they're two different openings. They're separated by a very thin membrane, though. So a lot of women do feel like, especially my older women, they don't really look down there. It's very taboo. They don't know that those two openings are separate. And above or towards the top of the belly, so this is a lady who, when she's sitting down, her butt cheeks are on the bottom and the pubic bone is on the top. Her anus is a little opening at the bottom. I don't know if I can get us. Did that go on there? No. Or maybe do I have a pointer?
Yeah.
Is this the pointer? Ooh, okay. Anus. So here is the clitoris. And so for patients who, can have a clitoral orgasm, that would be a masturbation spot. And during intercourse, if you stimulate that enough between the two people rubbing, you can have an orgasm with that. Some women don't, though. Some women, even with touching of their clitoris, cannot have an orgasm. This is where you urinate out of. That's the urethra. Here are the labia, and this is the vagina. So the labia here are similar to the testicles of a man. So they are, of course, but they're testicles for women. And the clitoris would be similar to a penis, the glands of the penis. So when we're embryologically being developed, depending on which chromosome is present, will either turn on or off the sex, your sex organs. So women can get stimulated from their vulva, which are the labia majora and labia minora, okay, as well as the clitoris. Actually, I was reading just recently about, and I forgot the name of it. It's I should have written it down. The massage that is on the vulva. I think it's Teutonic massage, where it's a massage where a masseuse, like, okay, now where are people getting these types of massages? Okay, I'm not judging, but I've never gotten a massage like that, because they actually put their hand over the whole vulva and they massage back and forth. And then, of course, during like this Wikipedia explanation of these massages, they're like, and sometimes orgasm occurs. I'm like, you think so? But it's a very erogenous massage. But because all of the vulva for a woman, including the clitoris and inside the vagina, are parts of our erogenous zones and our sexual zones, as well as breasts, right? And other places in a woman's body. So guys always ask me, where is the G spot? Nobody knows where the G spot is. Do women have a G spot? Some women do, but not all women do. Okay. But some women have a spot inside the vagina that can be stimulated and can cause an orgasm. So that's the question the guys are always asking me, like, where is my wife's G spot? If you find one, it's there, and then use it, enjoy it, because not all women have it. And when they do MRIs and they do anatomy dissections, there's nothing that anatomically is like a clitoris, right? Like an organ. But it is the G spot they think is a neural network that does exist at certain locations in a woman's body that are pretty common. And that would be if I was doing, or look, a gentleman or whoever was having intercourse or putting fingers in this woman, if they went in her vagina, went in about 4 to 5 centimeters on the top part, so facing up towards her pubic bone, and that was stimulated, that could cause an orgasm. But not everybody has that. Not everybody has that in that spot, right? But that would technically be the most common location for a G spot that would cause orgasm. Sex. This is 2025. So you guys are all going to go home and try that. And we could talk about, there's lots of conversation that can go on outside of this talk. This is pretty much just like a textbook talk. So we're 2025. Masters and Johnsons. Do you guys remember Masters and Johnsons? No? Okay. So I remember, right? Yeah. Yeah. So when I was in college, my undergraduate degree is in human development and family studies, because I thought, if I don't make it into med school, what am I going to do with a biology degree? Not only that, if I do make it into med school, what am I going to do with a biology degree? They're going to teach me biology all the time. Like there's one biology class and a biochem class in medical school. What am I going to do with people when I talk to them if I don't know about human development and family studies, right? Like what better of a degree to have to go into medicine? So anyway, that was my undergrad degree, and we studied Masters and Johnsons in one of my classes. And the reason is because these two people, a man and a woman, um, were the first two people to study sex. And it's very interesting. And so 1950s. That means 75 years ago. This is new. Like we're such a Puritan society that nobody, like I talk to my patients who are like, oh, I don't touch down there. I don't talk. And like, oh, I'm so embarrassed. And it's really kind of interesting because I'm kind of a sandwich generation. I'm kind of in the middle of between my older patients and my younger patients, and what a huge difference. My younger patients, they're coming with information like, yeah, I don't know what you searched on Chat GPT or Google or whatever AI. That's not really real, right? And then I'm talking to my other patients, I'm like, okay, well, this is like something that you can look up. But so, too much information, not enough information. I'm somewhere in between. Masters and Johnson 75 years ago were the first people who really made sex a science. So they took, I think, like a couple dozen couples and observed them having intercourse and documented it and talked about it and made it a science. Like, this is what happens. And this is the beginning of it. And this is how they have climax. So it was really interesting. They documented everything, they opened up, they were the first people to open up sex as a topic, that this is something people do. It's like eating or breathing or using the bathroom, right? It's normal. And so what they were able to do is, as they started, observing the couples that they were doing all these scientific observations on, they noticed that there's arousal, and this arousal goes over time. There's excitement, you get excited, then there's, you might not get more excited, it stops. And then it vamps up and you orgasm. And after orgasm, you're just exhausted. And that's called the resolution phase. So they had it kind of like documented, like there's 4 distinct phases during having sex. And, the time may change between one to the other, but this is how it goes. Which kind of nice because it kind of helped us understand like that sex wasn't just, a light switch that went on and that different things were happening. But this was, of course, the very beginning, right? And then they discussed that changes can occur with arousal, excitement, and or orgasm. And this opened up the doors, right? They're the first people to talk about sex. Nobody's talking about sex in our culture, because there are other cultures that have books about sex, like the Kumasatra, I think is what it's called. If my memory serves me right, I haven't talked about that in a while. But there are other cultures that talk about it much more openly than our culture. Our culture just in America doesn't. So when we talk about initiation of sex, let's go back to the Masters and Johnsons and some of the things that they started talking about. And I think we still rely a lot on some of their terminology, because really sex hasn't changed physiologically in human beings, as far as we know. Different things have come up in terms of like maybe lubrications and toys or eroticisms, but really, nothing's really changed in our biology, right? So on the initiation of sex, you have desire and you have arousal. And how we talk about those two as two different things is desire is something that happens in our brain. Remember, I told you about children not having any idea of sex, right? They go through puberty, they start getting these hormones, desire, right? They don't know why they're feeling that way, right? So their brain has something they want, right? And the arousal is, ooh, I want to have sex, right? So it evokes or awakens a feeling or an emotion, then your body starts to change, right? And we see blood pressure change, we see dilation change, we see vaginal lubrication or erection, either erection of a penis or erection of the clitoral gland. So the clitoral gland, I'll go back, right here, gets erect as we start to get aroused. And so that gets bigger. You might not see it, but it does. And there's more blood flow. So we have desire, we have arousal, we think the brain, the body, right? How many, and because, we're all women, and, you get home, the dishes aren't done, you got to cook dinner, and your partner is like, hey, right? And you're like, no, right? Because your brain is like, I got to do these dishes, I haven't cooked. And you just walk in and you're like, hey, that's another word for sex, right? So we have the brain and we have the body, right? The guy's like, yeah. Or even if the girl wants to, her brain's like, no, no, right? I've got all this stuff to do. The kids are here. I've got to get them to bed or whatever, right? So you have to have both, right? When we look at problems with initiation, okay, so what happens with our brain that makes us not want to? Obviously, situational, right? But there are other things that we can't control, right? Menopause for women, right? It has a bit hormones, right? Menopause has a big impact on libido and sex, right? And that happens when we surgically remove ovaries or we go through natural menopause and the hormones are gone in our body. Chronic oral contraceptive use can decrease your estrogen, and you can have problems with desire. Premature ovarian failure, lowering of estrogen as well. Okay, the body, what can happen in your body? So those are some brain things that are affected by hormones. In the body, you can have vaginal dryness. Hypertonicity just means the pelvic floor muscles are really tight and contracted. Inability to orgasm, and inability to feel a lot. And these can happen either even before menopause, very common after menopause, except for hypertonicity. That's a separate issue in and of itself. Oral contraceptives. So birth control pills. So birth control pills are typically, with the exception of one newer birth control pill, they're ethinyl estradiol, which is a synthetic man-made estrogen. And it's in micrograms, very, very strong. And it will shut down a woman's entire system for ovulation so that they don't get pregnant. But in doing that, as it shuts down the whole system, then you don't make hormones, right? So your estrogen can fall super low. I remember when I first started, this is in my private practice, in mainstream OB-GYN, nobody wants to do hormones. I don't know if anybody's ever experienced that, but when I was trained, we don't test for hormones because it doesn't matter. I'd be like, okay, right, it doesn't matter. You're either A or B and we just treat. Then when I got into my private practice, patients started asking me to test for hormones. So I started testing for hormones because, I'm curious as well as what are their symptoms and do they have hormonal problems? Are these things we can detect? So over the years, I started testing more and more women for hormones. I have learned so much just by having woman after woman and looking at these results. And I remember having young girls. And I'm like, oh my gosh, you have zero estrogen. I'm like, are your ovaries working? I never put one and one together that they were on birth control pills because no one really told us that you can test hormones and you can actually see that their estrogen is zero. So when my patient's like, look, my young girl who's in her 20s, I can't have an orgasm. I'm dry. Well, of course you are. You're like a menopausal woman, but nobody ever makes that connection. Of course, I went to school 25 years ago in my training, so things have changed a lot. It's only been 75 years for Masters and Johnson's. I'm like 1/3 of the way back, right? Oh my God. Time goes fast. Okay, so birth control pills do a lot to a woman's body, right? And we, as physicians, I distinctly remember asking my teachers when I was in school, what's the difference? I was always confused. I said, birth control pills are in micrograms. That's like a grain of sand of hormones. And when I give my hormone replacement therapy to my menopausal patient, they're in milligrams, which are like donuts, right? It's substance. Why such a concentration difference? Why am I giving my young girl such a low amount? And I never really got the answer I looked for. I read Inside Spiroff, which was the reproductive endocrinology book, which had talked all about hormones, and they didn't say anything there either. Fast forward to the last few years where I really started delving deep into hormones, mainly because my patients are asking me and I didn't have the answers, and that bothered me. So I kept reading and reading and reading and asking, going to classes, eventually ending up with another degree. But I found it's because oral contraceptives are synthetic. They're not biologically identical to a woman's body. So it's like they're really strong, right? They shut down an entire woman's body. But when we give our hormone replacement, those are biologically identical. So you have to give bigger doses so that your body can have the right amount. Because they act very similar to what our body made, and we're going to have different stress. Very interesting stuff. Anyway, I diverged. So arousal in the body, you can have problems, right? You may want to have sex, but if you don't have any estrogen, you go to have sex and the penis goes in and it just kind of stops because it's so dry, right? Your partner doesn't care. Partner's like, that's okay. We'll just put some water, get you all wet, let's just have sex in the shower. You're like, they just don't understand that when you become dry, you not just become dry, you lose your elasticity. So my favorite analogy is a rubber band. So you take a rubber band out of the box, it's brand new, and you stretch it, it bounces back, right? It's like good elastic on your panties, right? Time goes on, you stretch it, and you get those little cracks, and then you stretch it, and it just breaks, right? Like when you put on your panties and they kind of fall a little, you're like, oh, okay, that elastic's gone. So when that elasticity goes away and that penis is trying to get inside and it's stretching a small vagina and it's going bigger, it doesn't want to do that. It starts to break, it starts to cut, it starts to bleed. It's uncomfortable and it wants to go back, and that's atrophy. That's really postmenopausal atrophy. That's when things are dry. Okay. So when we think about, so what happens is that puts up barriers for women because they're like, gosh, last time I had sex, that really hurt. Now all of a sudden the pelvic floor is like, not doing this again, right? So then you go and you get different stuff, which I have a product back there. It's Uber Lube. It's a silicone base, one of my favorite. It is silicone, but I like it because it is the WD-40 for the vagina. And if people like water-based, then I recommend Sliquid or Astroglide. Astroglide is in like every store. Over the years, I think Astroglide just got too big for its name. It seems to be more watery to me. So I do like Sliquid. Easy way to remember it, it's liquid with an S, okay? So when we talk about a little bit about arousal and body stuff, okay? Now, this does nothing for your ability to orgasm, okay? This just allows a vagina to have penetration without discomfort, okay? All right, next one. Sex hormones and neurotransmitters. Big fancy words, we'll go through them really quick. Do they mean anything? No. To you guys? No. Do they mean anything to me? No, because I'm not going to do anything about these. They're great to know for science, right? Desire is from dopamine, estrogen, serotonin, testosterone. Arousal, we find there's changes in dopamine, estrogen, norepinephrine, prolactin, the feel-good love hormone, which stimulates oxytocin, and serotonin. People know serotonin from SSRIs, the antidepressants, the serotonin reuptake inhibitors, right? So when you have high serotonin, high dopamine, those are pleasure. Those are all the feel-good stuff in our brain, okay? Lots of different chemical reactions. Estrogen, those are the women's, lovey type of hormone. Testosterone gives you that sex drive. Well, this is what we think, right? The estrogen is the hug me. The testosterone is I want to get it on, right? So that's kind of like a generic way of thinking about those hormones. The other ones are just brain hormones that we don't do anything about unless maybe you're on an antidepressant. So that's why when you're on an antidepressant, then you have some decrease in libido. Hormonal, what are treatments? I put these down here, but truth be told, there isn't any magic prescription that anyone can give. Because like I said in the beginning of the talk, we don't know really what that one thing is that gets that prepubescent person into puberty and that sex drive gets created. There's not one thing, right? There isn't one thing that happens, right? We know that estrogen, when you lose it, you lose a lot of your libido. Well, if that's the case, and that's the one here all and end all, why are my patients' sexual appetite, ability to orgasm, and everything else coming back with just one script? It doesn't. Sometimes it's a combination, and there's lots of different factors when it comes to sex. For hormonal, our big players are estrogen and testosterone, the female hormone, the male hormone, okay? Female hormone, I want to hug you, I love you, soft, cuddly. Testosterone, more of the male hormone, but women do have it. Men also have estrogen, okay? So that is a different talk for men. Testosterone is non-FDA approved for women, but we're giving it more and more. And there's more and more we're learning about it. Even DHEA which is not in this slide, mainly because it's very, very much off label. And I get enough success with testosterone and not having to give other stuff, but there are other things we can always tweak. Prosterone is the DHEA. It's the way this is written is it's vaginal, but you can give oral, which, now as time is going on and these things are becoming more prevalent with our menopause, women are screaming, right? Because it's my generation. We're computer savvy. Our voices are being heard. We're pushing back to the physicians. We're pushing back to the medical community that we want a better life, right? The women who are older than us that are in menopause, they are the pre-computer generation, the generation that's a little bit more about, this is taboo. I don't really talk about sex. I really don't know how the internet works. I'm making generalizations. I have a lot of computer savvy older women, which is great. But, just in general, as menopause, as women in our generation are going through menopause, we're becoming more vocal. We want more. We demand more treatment. We're not going to live a life that we feel is not to the best of what we want to be. Aspermethrin, it's not really contraindicated. It's just it's a estrogen modulator, estrogen receptor modulator. It's very expensive and it's really meant for like dryness of the vagina and pain with intercourse. So it's not really like I prefer something that's less expensive and more biologically identical. That's a DHEA. I'm sorry, that's a SERM. And then the other one's Prestone. They're okay. I just don't give them as much because they're very, very expensive. Speaking of expensive, we get to medicines that are for libido, right? Now, we all know men have Viagra. And there's a lot of different reasons for why men have an erection pill and women do not. And that's a whole different lecture because there's a lot of, for me, as a physician, there's a lot of personal speculation on why women don't have adequate treatment options and why we don't have the science that supports our problems. Like we have an issue. Where are the studies to treat us, right? Where is science saying, hey, let's try these new drugs to get women to have an orgasm? I have a lot of thoughts behind that, but it's not for this platform. We do have two non-hormonal medications. One's Addyi, it's about $960 a month. And it increases the ability to have an orgasm. So if you could have 3 orgasms in a month, now you can have 4. Ooh. I'm going to go buy that for $1,000. And then there's Valesi, which is an injection, just about the same. These are expensive medicines. They're really hard to take. You can't drink with them. With the I think with the Valesi you can't. I read about them when they came out. I was really super excited. This was a few years ago, and then I forgot about them. I only talk about them when I go in a lecture because if I have to give them to a patient, my patient can't take it. And why are they going to take it for such a little bit of improvement, right? If I was going to give you something that said, hey, you're going to have 2 orgasms a day, anytime you want for $960, their partners would be buying it for them, right? But if you're going to have a 0.5 a month or one time more a month out of, from 3 to 4, and the literature says you're going to have a 25% improvement, of course you're going to have 25% improvement. No, from 3 to 4. Do the math. That's not a lot, but they're going to advertise it as, oh, look at this big improvement. And then you can't have any alcohol because you lose your blood pressure, you get hypotensive. So and you have to sign like a form. There's like they had us, I was reading about it, and to become a practitioner and prescribe it, I have to give a form to my patient that she agrees with me to not have any alcohol while being on this medication. I'm like, look, after she pays $960 and has a half an orgasm more a month, then she can't drink. I'm not a drinker, but it makes me want to drink. Okay, anyway, so menopause. Menopause is a big problem or big reason for why women, have problems with sex. We talked about the vaginal dryness and the low libido. Hot flashes are just part of menopause, right? And some treatment options are diet changes. You can layer clothing, hormone replacement therapy. There are some newer medicines on the market now that are not hormones. So patients who have breast cancer or other reasons why they can't take estrogen, then we could do that. Vaginal dryness, the regular topical lubrications. Replens is really good. Progesterone is the DHEA that goes in the, and then estrogen. Those are the vaginal. Low libido, really, there's not anything that treats a low libido. Like I can't give a medication that says, your libido will go up. Testosterone gets the closest to it, off-label use, sometimes higher doses, sometimes very low doses. My patients typically do like it. But what's cited in the literature is go sit down and talk about your problems, right? So we're going to go talk to a therapist why a guy takes a Viagra. Life's not fair. Okay, in terms of the non-hormonal, it's a I can never say these, fezolineide and alizinate, and well, you guys can read, so then I won't try to butcher the words. So these are kisspeptin, neurokinin B, and dynorphins. The second one, the alizinate, that's an interesting medicine because I read probably a week ago that that's just becoming FDA approved, but I've had it on my slides for a while, so I know it's been out there. Some of the problems with these medicines for these are hot flashes, is that you can have some liver damage or an increase in liver enzymes. Some of the literature says it's a black box warning. It's not really a black box warning. I've tried the medicines. I think they work really well, but they do have some side effects. And it's just for hot flashes. It doesn't do anything for your sex drive. But if you're waking up all night and you're not sleeping, you're not feeling good, may affect your libido. Or you wake up and want to have sex. This is the intimacy-based model. So when we start talking about cognitive behavioral therapy, they kind of go through these types of things like, where is your problem? Do you have emotional intimacy problems, right? Because, we can't take a pill, so all we can do is really talk about it, right? Are you being sexually stimulated? Do you have a spontaneous sexual drive or not, right? And then is there anything biological, right? Your hormones or, have you had surgery? Are you on anything for, chemotherapeutics? And then sexual arousal. Then, of course, we go into the Masters and Johnson's type of thing, arousal and desire and emotional and physical satisfaction, right? And so, of course, that leads into the abuse in the relationship and, are you having pleasure with intercourse? But this is what we have, right? We can talk about it all day. Makes me just want to run home, right? So I think that when it comes to sex for women, there are not a lot of really good treatment options. One, because it's only been 75 years that we've really gotten out of our thought processes of starting to talk about sex. Second, now we have to really come across and say, okay, what are the things that are out there? What can we do? And can women be studied more? One of the problems with studying women is the fact that we can get pregnant. So you never want to give an experimental drug if a patient can get pregnant. If we want to keep a woman from getting pregnant because we don't want our fetus to have any hormones and stuff, and if we don't want the woman to get pregnant, then we got to put her on birth control. If we put her on birth control, then you have the problem of synthetic hormones. So that is a big problem on why women in general have not been studied as much, as well as I don't think that, I still think we're of that culture where women should not be talking about sex. And I love the fact that now we're talking about menopause, we're demanding better treatments, we're demanding a better quality of life, right? And I think that push, whether it's on a social platform, whether it's with our girlfriends in our community, with our doctors, it's going to trickle down in a grassroots type of movement over the next generation that hopefully there will be more answers to having women have intimacy and be able to orgasm even after menopause. And menopause is the biggest issue for that, but not all. I have a lot of younger patients too, and patients in their 40s who are perimenopausal. So in the end, sexuality in women is complex and it's poorly studied, therefore poorly understood. Perhaps our social, cultural, and religious constructs have defined women's sexuality, creating barriers to treatments and have hindered openness to allow freedom of sexual expression, right? And I haven't even talked about, how young girls, are labeled when they have a sexuality or if they have a sexuality or, what it's like for a young girl to lose her virginity versus a young boy to lose his virginity and how we view them in society and how, there's shame and there is, other things that I think girls end up growing up and thinking about themselves when it comes to sexuality that hopefully over the generations and years will change. but that takes time, right? And until then, we have what we have in terms of estrogen. Progesterone is not for sex, but when a woman has a uterus and she's given estrogen, in menopause or perimenopause, she needs progesterone to protect her uterus. And then testosterone is being used in more and more. Off-label use, because the FDA still hasn't sanctioned it, and it has its pros and cons, but it's what we have, right? It's what I have as much in my toolbox as, as the science has allowed me to give, right? I can't create a substance. So when that starts to change, then, we'll hopefully start to get to use it all. And hopefully it's time to get back in the game. I guess that would be another way of calling sex, right? All right. Well, thank you very much. And I'd like to leave this open for questions if we have time. Yes. Yes. So the O shot is a shot that is given. It's very interesting. It's off-label use. So I always start off with that, but it doesn't mean just because something's off-label, testosterone's also off-label. So the O shot is it's off-label use, but it's being studied more and more as one of the newer type of techniques. And it's not that new because it's been out for at least 10 years that I know of. The O shot is a shot that's given in the vagina, okay? And everybody's eyes bulge up. So let me back up and let's talk about what type of shot, right? So a patient will come into the office and we will draw their blood, okay? And so this is all natural, which is what I love about it. So I do the O shot for patients. We draw their blood, we take it out, and we put it in a special machine that will spin it at a special rate. And all of a sudden, we call it liquid gold, the blood will start to separate, okay? And the red blood cells and the white blood cells, because they're heavier, they go to the bottom. And then what elevates up is the platelet-rich plasma. Platelet-rich plasma has growth hormones, has endothelial growth factors, platelets, and those are regenerative. So when you look at regenerative medicine, part of my integrative health medicine fellowship, and the things that I'm currently studying and will continue to study because it changes every day, we take that serum off the top. We call it PRP, platelet-rich plasma. We put it in another syringe, and there's two places we inject it. We inject it right underneath the urethra. So here's clitoris, urethra. We go in the vagina, and just right about in there, we give a shot. Now, you're like, oh, I don't want a shot in there. So we use numbing medicine that actually works really well because the inside of the vagina it's not like our skin out here. The inside of the vagina is like the inside of your mouth, right? So things get absorbed really quick. So numbing medicine works really well there. So I just slather it on, take a little needle, and then I place it in there. Not only does it help remember we talked about the nerve endings we can't find them, but they're in there, and it's called the G spot. Oh, look, this does that. Okay. That's our Grafenberg spot, the G spot. So what we think is that when we put it in there, it helps all of those nerve endings regenerate, especially in perimenopause. And so orgasms and pleasure become better. As it also helps all of those regenerate, it helps the muscles regenerate. Women who leak urine, there's a nice success rate for urinary incontinence. So you get urinary incontinence, sexual pleasure, lubrication, elasticity, because it's a regenerative, right? We've taken everything that's good out of your cell and put it in one spot, and we've concentrated it, and it helps all of those cells start to act and heal and become better. I think of it like this. When we get scratched and we start to bleed, our body sends our platelets to create a clot over it, and then we have all the healing growth factors, and all of a sudden our scab will fall off and we have brand new cells. We've taken all that regenerative stuff, how our body magically heals a cut, and we put it in the vagina for it to magically heal and recreate our sensation. Then we also put a little bit, because I said this was like the penis, the clitoris, we give a shot right next to the glands of the clitoris. And that goes inside there, and that will help re-stimulate some of the nerve endings and the blood supply to the clitoris. So the thought process behind that in menopause is as you get drier because of the lack of estrogen, that will help recreate all of that, those nerve endings that have started to not be so responsive, to help them regenerate, right? But we do that in younger women too, not just menopausal women. So that's the O shot, and the O shot's all natural. So you eliminate, using someone else's product, someone else's, you're not, the side effects of using your own blood are none, because you're using your own blood, right? You're not going to reject it because it's yours. It came from your own body. It's not being from another person. And it's not a medication that has a side effect as well, because it's from you and it goes back into you. It's just that we've concentrated it and taken the red blood cells and the white blood cells, which could be, inflammatory, and we've given all the growth hormones and placed it very locally. This shot, so my personal treatment plan is, this is a cash-based, it's off-label, so it's cash. So, I always take pause to patients' pocketbooks, right? I'm just sensitive that way, right? So, and I'm not a salesman. I'm here to help my patient get to their goal. So I personally like to start off with hormone replacement therapy that's FDA approved, that you go to a pharmacy and it's going to be the same thing all the time, right? And see how a patient does. And depending on if they're in menopause or not in menopause, do they want to do topical testosterone? Do they want to do gel testosterone? I don't do pellets. I can do pellets. I prefer something that's a little bit less strong. I'm not opposed to doing pellets. I just haven't had patients who want to do them yet. Because this is still pretty new for me in terms of all the testosterone that I'm doing. Just because I've become a lot more comfortable with it as a practitioner. I really have to be comfortable with, side effects, because, they drill in your head during residency that, these are not FDA approved and everybody's going to grow a mustache and talk like a guy. Doesn't happen, and I think that it's a disservice to women, to say that testosterone is going to automatically do this, when you can watch your patient use doses and vamp them up as time goes on. And it's just a conversation. Can those things happen? They can. Depends on how much you use and how much you give a patient and who the patient is, right? And so, you're careful with your patient. It's a conversation. You bring them back in, you see how they're doing on the testosterone. You could check blood levels, and since I've been doing it forever and I've got a nice idea, we look at what happens, right? So I like to do those things first, because they're the cheapest for my patient. They're reversible for my patient. If my patient doesn't like them, she can stop them immediately, and the next day she's better, right? It's all gone. And I like that, and then we can go into things that are more long lasting. Hey, I really like this. Okay, then let's talk about maybe you want to do a pellet. And most of my patients still don't, because pellets are expensive and they get the same effects from doing creams. Then if they're not better, we go to O shot. I do have some patients who want to go right off the bat, but O shots are not guaranteed. So individual results vary. And so I'm always very careful that someone drops a lot of money and may possibly not get the effect that they want, right? So I'm always very careful that we've exhausted everything that could be the least costly to somebody, and then go on to that. But I do love PRP. I just love platelet-rich plasma. You had another question in the back? Oh, people do both. You do all of it. And I would recommend to layer. I like to layer stuff. And I like to start from the least invasive, least expensive, most reversible, least amount of risk, more mainstream, and then diverge out on their journey, right? So I hear what my patient wants, but as a practitioner, my goal is to help them, have things that work, and have things that they like, and have things that are okay. Well, we've tried all these things and you're not better. Are you interested in spending the extra money to try this? Or you've tried all this, it works, and you want a little bit more. Okay. We also use the O shot in the penis. So it's called the P shot. So you look at all those hair transplant places, they use PRP in the scalp, and that's how hair is regenerated. So you talk about people who have bad knees, they take that PRP and they put it, the orthopedic surgeons are putting it in people's knees and people's shoulders. So PRP has been used a long time. It's in regenerative medicine. It's very safe, and it's put in all different body parts for all different reasons, right? So it just depends on what you want to use it for and where you're putting it. It's safe. It's yours, right? It came from inside of you. It's under a sterile environment in a tube, and it goes back in you, right? So you're not going to have what we call graft versus host disease, right? When I put something in a patient, they have that possibility of rejecting it, whether it's a medication. And usually we talk about like grafts in terms of like maybe mesh that's placed in people, whether it's synthetic, meaning plastic, or if it's like porcine, which is pig, or other animals products and things like that, or injections, right? You have fillers, you have Botox, you have all sorts of stuff, right? This is your own body. So when we put it in, it's got all the good juju that helps the body kind of regenerate on its own and heal. And I think that's personally, I think that's really where medicine's going to go. They did take stem cells off the market and exomes. So there's, regenerative medicine took a big hit, and that happened in August last month. So everybody in the regenerative medicine field, which is a big field, is they're sad. But I like PRP, and that's enough for me. Yes.
Like,
Mm-mm. No, this is just for incontinence or orgasm, right? And so in terms of incontinence, it helps and nobody knows why it works, but it's placed in the area where I do a surgery for incontinence. It's the exact same location. And this is put in there. So, and that person who created this product or this technique is not a surgeon. They don't do incontinence surgery. So it's interesting. I think I should have asked them, because we were at a dinner a while ago, this summer. I should have asked how they really came up with that, right? So anyway, or why they got that location, probably just from the regular anatomy, I would imagine. But it helps it all regenerate. And so hormones are different, right? So your teenager is not getting PRP. They're having hormones. Something's happening physiologically that's in them. It's not really going to be a PRP. PRP is going to be regenerative to whatever neurons or nerve endings that are in that anatomy. So directly into the glands of the penis, directly around the G spot, right? When we talk about hormones do other things, right? Their elasticity for the vagina, PRP can do that, but PRP is more for orgasm. No matter how much I give to my patients of estrogen, typically their orgasm, like 98%, their orgasm is not going to change. Maybe it might with testosterone. So I do layer it because I like testosterone. I like testosterone a lot, but I do start my patients typically on the main two, estrogen and progesterone. Then I layer with testosterone. One of the reasons I like to do that is because I like to see what side effects are. I don't want to like slam my patient with 5 different things and they come back and they're like, "What, Dr. Furlong? I'm seeing 3 people." Okay, why are you seeing 3 people? Which medicine did I give that made that happen, right? Nobody sees 3 people, but that's my point. My point is if they have an issue and you've given several different things, you don't know which one they really don't like or is not agreeing with their body. So I start off really slow. I'm very conservative. Try this out. Try it for a month. Make sure you like it. What are your side effects? Come back, talk to me. Do we need to increase your dose? Do we need to change the route, right? I'm always about transdermal, meaning I like to give it through the skin. I don't give estrogen by oral because it changes. We give it through the skin, so it has really nice effects. Either I give skin patch or gel. And I like both. I have preferences, but both as long as it's through the skin. And then when it comes to testosterone is off label. So I give it, they know they have to pay cash for it. And then there's a couple different ways. I try not to use compounding pharmacies unless I have to. For vaginal preparations, it has to be, for me, a compounding pharmacy that I've worked with. That's a really, really good compounding pharmacy. I know lots of physicians use it. They're just really well known and they're very reliable. They're not like, a small, tiny little company brewing up medicines. They're a big organization. You can find them. They're very legit. and have a really good I guess reputation is pretty much it. And they're just very well known. There's a couple in the country that are just super big, and they're one of them. I don't say their name because I just don't I don't try to market for other people. So I was trying to say that without saying their name. But I use them, and so if my patient wants a compounded drug, then I'll get their testosterone from there. I try not to give hormones compounded. One, because they're very expensive, and you can get it covered by insurance, and they're biologically identical. They're exactly what a compounded pharmacy would do. So I try to give them, again, cost is always something I think about for my patients, right? Cost and convenience, right? I have patients that come to me and they're spending $400 or $500, and I'm like, oh, let me write you a script and it's $20 pay, right? At their pharmacy. And it's the same exact thing as a compounding pharmacy is going to give you, and you spent much less. Yes.
Hormones, the bio.
Right. So when you look, how are they? They're structurally identical. So when you put them through a mass spectrometer, it's where you look at a molecule under different light, and how that light will refract back, can tell you how many carbon molecules, how many oxygen, how many hydrogen, and what that chemical structure is. So when they put it through that spectrometry and that light comes back, they can tell you, well, this molecule looks like this. So estradiol is what your ovaries produce. That is exactly the prescription. It's not an ethinyl estradiol. It's not ethanol, because ethanol is synthetic. It's man-made. It's similar to estradiol, but it's off by a carbon. It's off by I think a methane, a CH3, or a carbon molecule. It's off by one. And that makes it different. So when it goes into your body, it's like genetically modified food, which is a whole different topic we could all talk about on my integrative medicine lecture. When that goes into your body's like, whoa, what's this? Oh, that's not, let's shut down. You could take that in micrograms. That's your grain of sand medicine, because it's so strong. It's not identical in your body. Estradiol is identical. So you need bigger doses because it's got to work just like regular. Right. And so when that goes through your body, well, there goes your brain fog, your joint pain, right? There's a whole article, and I'm just loving to see the literature come out every day. It's something new about estrogen. So like last week, I read about a study that said, oh, estrogen may help stop the risk of dementia. I'm like, you think? Because I can tell you, my patients come to me and they're like, I know I'm not going crazy, but I just can't think the way I used to think. Well, what was the one change you had? You went through menopause, your estrogen went away, right? It doesn't take a rocket science to look at the WHO. Okay, you're going to get me on my soapbox. The WHI study came out. We took everybody off of estrogen, right? Oh my God, everybody stop estrogen because you're all going to get breast cancer and die, and you're going to get heart disease, you're going to die. Seriously, when I was 2003, when I was in medical school, my PharmD sat next to me and went through everything in that study, and we all, as students, looked at how flawed it was. 22 years ago, I saw that. Can't change anything. You can't change what people thought. They just read the synopsis. So, when you look at the fact that all of that medicine, and this is just, we'll have to see what science says eventually, but you look at a nursing home for dementia and Alzheimer's, and you tell me what the ratio of women to men are, right? These are the women that we took all off of hormones. You tell me that estrogen doesn't affect the brain. I don't know. That's just an observation from me. Mm-hmm.
So I guess what I'm hearing is, it's really hard to hear that, because I think that that's exactly what they did for me, and that in my stage of going through menopause.
Mm-hmm.
And I was on estrogen and I was on a patch,
Mm-hmm.
but they kept telling me, like, you're gonna get cancer, you're gonna get cancer.
Right.
One doctor, and then another doctor, which was my oncology doctor, but I'm more worried about your, my heart disease. Mm-hmm. So I'm gonna put you back on a patch. Mm-hmm. Doesn't matter, they still took me off until now I'm gonna go do it naturally. And that has been like just terrible.
It is. I have analogies for that on the men's side, but We will save that for the off the mic conversation because God forbid if a man should go through this. I guarantee you that treatments would be different for women. But you have to look at my last slide, and then I'm going to end our lecture because I can talk about this forever. But here's my last slide. Perhaps our social, our cultural, our religious constructs. Think of how we view women. 75 years ago, Masters and Johnson started looking at sex. How much has changed? In 2000, I started medicine 25 years ago. I am just studying hormones 25 years into my career. Well, I have been for the last, 10 years, but I mean, really coming to fruition on this, right? And saying and hearing the voices, right? We have to start changing things on how we view women, right? When a girl starts dating boys and how we how we talk to our girls, about their sexuality and who they are, and how we embrace women and our own sexuality, and that it's normal and it's natural, and we are sexual beings, and there's nothing wrong with it. Not just okay for a guy to be sexual; it's okay for a girl. And whatever that means for your religious construct, I'm not saying about promiscuity. I'm just saying that the shame that women feel, we carry that into our menopause years of now, now I'm so happy I can't have sex, or I don't want to, I'm not supposed to, right? All these things that, yes, no, where is it for us? And, how do we treat ourselves to give ourselves the hormones we need? Because there are a lot of people who think you give women hormones and all of a sudden, they're promiscuous, right? All sorts of things, right? It would be nice if I could just give those out and make everyone promiscuous. All my patients would be happy. Like, yay, Dr. Furlong. But hormones are awesome, right? And the more we're learning about them, the more we're understanding that they're safe. Again, you see your physician, you follow up, you make your appointments, you do testing if you need testing. If you don't need testing, then don't do it, right? Depends on where you are. And there are lots of benefits for hormones, right? Cardiac, brain, joints. Some of the stuff goes a little, it always makes me laugh. Like, you can put it on your face. Like, okay, well, we'll see. There are some studies, but I don't know. I'll leave it at that. Okay. Well, thank you everybody for coming. I hope this helps you understand how little we know and how little I've advanced your knowledge, right? And I think that's important, right? Here I do this, for the last, 25 years of my life, and I feel like I'm just scratching the surface. It's interesting. So hopefully as time goes on, we'll just keep getting more and more, and it will get better and better. So spread the word, talk about it, get active in your community.
Thank you very much.
You're very welcome.
Always excellent.
Thanks.
Always fun to listen to. Dr.